so much, Dr. Salim, and Assalamu alaikum. It really is my pleasure to speak to you all today about our international evidence-based guidelines. And these are my disclosures. So I just wanted to begin by reminding everybody that PTH is the main regulator of serum calcium. And when serum calcium goes down, it is sensed by the calcium sensing receptor and PTH increases. So if we do not have PTH, then we will not be able to reabsorb calcium through the kidney, because every day we filter 10 grams of calcium through the kidney and we reabsorb 9.8 grams. That's 10 times what we take in orally. If we were to take 1 gram of elemental calcium a day, we filter 10 times that amount through the kidney and we reabsorb 9.8, and that requires PTH. So if we don't have PTH, then we will have hypercalciuria. And this will contribute to nephrocalcinosis, calcification of the renal parenchyma, kidney stones, and impair kidney function. Another important point that we need to recognize is that PTH binds to PTH receptors on the surface of osteoblasts, and it increases rank ligand expression and causes the formation and the function and the activity of the osteoclasts. And these osteoclasts will then resorb bone. And when they resorb bone, they will release calcium and phosphate into the circulation. So if we don't have PTH, we will not be able to take calcium and phosphate out of the bones. And this will result in hypocalcemia, and it will decrease bone remodeling and repair. And another important point is that PTH is necessary for the activation of vitamin D. And the hydroxylation of vitamin D, the 25-hydroxyvitamin D, to become 125 dihydroxyvitamin D is activated by PTH. So PTH enhances the hydroxylation of vitamin D. And through these three mechanisms, it increases serum calcium. So if we don't have PTH, we actually have two hormones that are missing. Not only PTH, but we're also missing 125D. And 125D increases the absorption of calcium and phosphate from the bowel. And it's very important in the normalization of serum calcium. So calcium homeostasis is regulated very tightly by PTH and the other calcium regulating hormones. So how do we make the diagnosis of hypoparathyroidism? So hypoparathyroidism is diagnosed if we have inadequate PTH, and we will have hypocalcemia because we don't have adequate PTH. So if we have confirmed hypocalcemia, calcium corrected for albumin is low, or ionized calcium is low, in the presence of low PTH or inappropriately normal PTH, then we can confirm the diagnosis of hypoparathyroidism. Because when calcium is low, PTH should be high. It should be reabsorbing more calcium from the kidney, increasing calcium release from the bones, increasing the formation of 125D. So if PTH is not high and it's inappropriately normal or low, then that confirms the diagnosis of hypoparathyroidism. And we have to do that on at least 2 occasions, 2 weeks apart. A couple of important points are, a lot of patients are taking biotin for hair. And biotin in some assays can give us low results for PTH. So if your patient is taking biotin, ask them to stop the biotin and then check the PTH. And also with human anti-mouse antibodies, we can have an elevation in PTH. With hypoparathyroidism, we see elevations in phosphate. Why does phosphate go up? Because this system has been so beautifully designed that when the first effect of PTH is on the calcium, so it causes calcium reabsorption, but it causes phosphate excretion through the kidney. So PTH has a phosphaturic effect. Why is that so important? Because look at the second effect and the third effect. The second effect is the release of calcium and phosphate into the circulation. So if we didn't have a reduction in phosphate prior to the release of calcium and phosphate in the circulation, the phosphate levels would be high. So PTH has a phosphaturic effect. And 125D increases the absorption of calcium and phosphate from the bowel. So these two effects will give an increase in calcium and phosphate. And this is why the first effect has been so beautifully designed that PTH enhances calcium reabsorption and has a phosphaturic effect. If we don't have PTH, phosphate levels will be high, and the high phosphate will bind with calcium and cause intracranial calcification, basal ganglia calcification, calcium deposits in the lens, causing cataracts, and it can cause calcification in the kidney, and so it causes ectopic calcification. Also, with hypoparathyroidism, we have low 125D because PTH enhances the conversion of 25D to 125D. Also, PTH is going to activate bone remodeling and repair. So if we don't have PTH, bone remodeling will be decreased and the bone will be dense and we will not be able to access calcium and phosphate from the skeleton. And also, we will have hypercalciuria because we don't have PTH to reabsorb calcium. And so the fractional excretion, urinary excretion of calcium will be elevated. We did a systematic review and a meta-analysis. This was done by the International Working Group on Hypoparathyroidism. And we published our results in 2022. And we know that 75% of people who have hypoparathyroidism have this after total thyroidectomy or neck surgery, parathyroid surgery, where the parathyroid glands have been damaged or the blood flow to the parathyroid glands have been damaged. And we wanted to know, how can we predict who is going to develop permanent hypoparathyroidism? Because many people have transient hypoparathyroidism after neck surgery. And we're saying permanent hypoparathyroidism is defined as having hypoparathyroidism 12 months after neck surgery. So who develops permanent hypoparathyroidism? And we looked at all of the global studies evaluating the use of PTH and or calcium to predict who will develop chronic or permanent hypoparathyroidism. And we found that if we measure PTH 12 to 24 hours after thyroidectomy, we are able to predict who will develop permanent hypoparathyroidism. If the PTH is less than 10 picograms per mil or 1.05 picomoles per liter, and those are the units that we use in Canada, picomoles per liter. So in Canada, we say 1.05. Our American colleagues use 10 picograms per mil. If it's less than these values, they have a higher risk of developing permanent hypoparathyroidism, but the risk is still less than 50%. So at 12 to 24 hours, check your PTH. And if it's less than 10 picograms per mil or 1.05 picomoles per liter, then there's about 50% chance that they could have chronic hypoparathyroidism, and these people need to be followed. If they don't have post-surgical hypoparathyroidism, which is caused by neck surgery and is the reason for the hypoparathyroidism in 75% of patients, then we need to look at the other causes of hypoparathyroidism. And in the global guidelines, we said that the most common cause is autoimmune, and it could be polyglandular or it could be monogenic. It could be autoimmune hypoparathyroidism. And it is important for us to evaluate these patients to see if it is syndromic or is it isolated hypoparathyroidism. And they can be genetic causes of hypoparathyroidism. And the genetic causes may also be syndromic. So it could be a mutation in the gene that will impact parathyroid function or development or secretion, and other organs are affected as well. Or it could be like autosomal dominant hypocalcemia, where we have an isolated problem, an activating mutation in the calcium sensing receptor gene, making that receptor supersensitive and resulting in hypoparathyroidism. So we need to know, is it isolated or is it syndromic? And then we look to see, is it infiltrative? Is it because of sarcoidosis or granulomatous disease? Is it because of mineral deposition, such as iron or copper? Is it because of metastatic disease? Cancers can infiltrate the parathyroid glands. Or is it after radiation? Or is it because of magnesium deficiency or excess? If we have inadequate levels of magnesium, that can cause hypoparathyroidism because magnesium is a cofactor of adenylate cyclase. And if we have too much magnesium, that can bind to the calcium sensing receptor and turn off PTH. And so we need to make sure that serum magnesium is normal because deficiency and excess, both of them can cause hypoparathyroidism. Also, patients can have transient hypoparathyroidism with severe burns or illness. And if the mother, if the pregnant woman has hyperparathyroidism, then the calcium will transfer to the fetus and it will prevent the development of normal parathyroid function. And the baby can be born with hypoparathyroidism. So we have to decide, why does our patient have hypoparathyroidism? Is it post-surgical or is it non-surgical? Is it autoimmune or all these other conditions? And that's where the endocrinologist comes in. We need to find out why our patient has hypoparathyroidism. And it is important for us to recognize that there are many complications of hypoparathyroidism. And if we look at autoimmune polyendocrine syndrome 1, it is because of mutations in the AIR gene. And this is associated with other important features. We also have oral candidiasis, and women can get vaginal candidiasis. They can also have adrenal insufficiency. So it is important for us to look for these other features of autoimmune polyendocrine syndrome 1 and evaluate the thyroid function, evaluate adrenal function, and look to see, do they have malabsorption? Have they had premature ovarian failure or gonadal failure? Do they have diabetes? Do they have pancreatitis? We are looking to see if they have features of APS1. And there are 20 odd minor features that we need to evaluate. And we can always do DNA analysis of the AIR gene. But if we have a patient with hypoparathyroidism, don't just stop there. Ask, why does my patient have hypoparathyroidism? Is it post-surgical or non-surgical? If it's non-surgical, we have to find out why. Do they have APS1? And so the approach that we are advising is that find out if our patient has hypoparathyroidism, exclude post-surgical, check magnesium, exclude infiltrative disorders, and then look to see if they have other conditions that would suggest a syndromic cause, or is it isolated? And we talked about the features of APS1. Do they have features of GATA3 mutation, which can be associated with hearing impairment and kidney disease? Do they have lactic acidosis, metabolic abnormalities? Do they have features of DiGeorge syndrome with a cleft lip, cleft palate, heart disease? And these are the features that we're looking for. If we find that they have syndromic hypoparathyroidism, then we need to do a more detailed evaluation, and our DNA analysis will include many more genes. If, however, it is isolated and it's only hypoparathyroidism in isolation, then it could be autosomal dominant hypoparathyroidism, autosomal dominant hypocalcemia due to a calcium sensing receptor gene mutation, which is ADH1, or GNA11 gene mutation, which is ADH2, or it could be a GCM2 gene mutation, it could be a PTH gene mutation, or X-linked SOX3 gene mutation. With hypocalcemia, our patient can have many features. They could have seizures. With hypocalcemia, they can have laryngospasm. The Chvostek sign, when we tap anterior to the earlobe, can result in twitching of the face. If we pump up the blood pressure, they can have carpal spasm. They can also get bronchospasm, and they can get carpopedal spasm. They get muscle cramping and muscle pain. And it can also cause cognitive impairment. And many young people who present with non-surgical hypoparathyroidism, they will have had these symptoms: numbness and tingling in the face and hands, muscle cramping, weakness. And these symptoms are more when the calcium requirements go up, such as during periods for women, or if they're exercising. And I recently saw a policeman, and the police officer said, when I have to run, I can't catch my breath. And he was hypocalcemic. And when he was running, he was actually developing laryngospasm and bronchospasm. But his diagnosis had been missed. So we did a systematic review looking at the complications of hypoparathyroidism, and we found that patients who have hypoparathyroidism compared to the general population are more likely to have calcium deposits in the lens. They can have cataracts. They can have infections because calcium is required for the immune cells to function. They can get calcium deposits in the kidneys. That can affect kidney function. They can develop chronic kidney disease. They can have seizures because a low calcium will lower the seizure threshold. They can get depression. They can get ischemic heart disease. They can get arrhythmias because hypocalcemia prolongs the QT interval and can cause arrhythmias. What about the effect of hypoparathyroidism on kidney function? And internationally, we have seen that people with hypoparathyroidism are more likely to have kidney stones, more likely to have impairment of kidney function, and more likely to have nephrocalcinosis, calcification of the renal parenchyma. What happens to the bone? Well, what we've seen is that the bone in patients with hypoparathyroidism is dense. They have increases in cancellous bone volume, in trabecular thickness, and a higher number of trabeculae with trabecular connectivity. And this in comparison to the patients who have hypoparathyroidism. And so we can see that this dense bone is not being remodeled, and this may actually impair the quality of the bone, because if it's not able to repair and renew itself, then microfractures could develop. Currently, we do not have any prospective data on fracture risk, but case control studies show no difference in the fracture rates compared to the general population. And in some studies, we have seen an increase in the upper extremity fractures in the non-surgical group in comparison to the general population. And we have seen an increase and a decrease in the upper extremity fractures in the post-surgical group. So the data is not clear, but we do not have prospective data. And recently, this study has now been published. We looked at a prospective evaluation of 100 patients from the Canadian National Hypoparathyroidism, and we evaluated these patients. They were pre- and postmenopausal females, as well as men, and 1/3 of them actually had osteoporosis by bone density or fragility fracture. So that's significant. So in the premenopausal patient population, we didn't see an increase in the risk of fracture, but in the postmenopausal patient population, we did. And our best practice guidelines are just being submitted for publication now. These are best practice recommendations. We are saying that everybody with hypoparathyroidism should be evaluated. We need to check the urine for calcium, creatinine, oxalate, citrate, do an ultrasound of the kidneys, send the patients for eye exam, check to see if they have cataracts. And if they have hypoparathyroidism for more than 5 years, do a CAT scan of the brain and check cardiac symptoms as well with EKG and Holter monitor, and evaluate cardiovascular risk factors. And for postmenopausal women, assess skeletal health with bone density and trabecular bone score. And also evaluate psychiatric manifestations and recognize the infectious complications. So when we treat our patients with hypoparathyroidism, we can give them calcium, we can give them active vitamin D. But if we give them too much, we can make the calcium too high. And the more calcium and active vitamin D we give them, the urine calcium goes up because they don't have PTH to bring that calcium back. So as we increase their serum calcium, the urine calcium is going up, and we're actually increasing their risk of kidney complications. And if we don't give them enough calcium and vitamin D, then they're going to have numbness and tingling and muscle cramping, brain fog, inability to think clearly, laryngospasm, tetany, and seizures. So it is not an easy situation because if we do not give back the missing hormone, we are really giving them band-aid treatment. Calcium and active vitamin D has GI side effects, and it will actually increase their risk of renal complications. So in these guidelines that we published in December of 2022, we made the graded recommendation that begin with conventional therapy with calcium and active vitamin D, but if your patient isn't doing well, proceed with PTH. And what does not doing well mean? Well, if they can't take all that active vitamin D and calcium, maybe they're intolerant, maybe they can't take 3 grams of calcium 3 times a day or 1 microgram of calcitriol twice a day. These are a huge pill burden, you know? So they can't keep up with that much load of the pills. Maybe they have fluctuations in serum calcium. The calcium could go up too much, or the calcium could come down because we're not giving them enough. Or if they exercise, or if they have to run for the bus, then they develop numbness and tingling and might go into carpopedal spasm. This is poor control. If their phosphate levels are high, because when we give active vitamin D, that will increase calcium and phosphate absorption from the bowel. So when we give active vitamin D, we increase the calcium, but we make the phosphate worse. And we increase the urine calcium, so we make that worse too. But an advantage of giving calcium is that it binds the phosphate in the bowel, and it can lower the phosphate absorption. But also when we give calcium and active vitamin D, we increase urine calcium. And so if our patient already has these features, then we need to give them PTH. We have to give them back the missing hormone. If they have renal impairment, if they have malabsorption, if they've already got ectopic calcification, they've got cataracts, then conventional therapy, which is this, is not adequate. Now, I want to highlight the fact that when we give calcium carbonate or calcium citrate, and we give 500 milligrams, give it with meals, always, and divide it throughout the day. And I tell my patients, you have to take your calcium with food. Every time you eat, take your calcium, because it'll bind the phosphate in your food and get rid of it. Plus, it will help to elevate the calcium. We have to replace vitamin D because there may be other tissues that are able to convert 25D to 125D. Other tissues can have the 1-alpha hydroxylase activity. And so even in patients with hypoparathyroidism, we need to ensure that we replenish vitamin D. And then we give active vitamin D, calcitriol, alpha-calcidol. You can start with 0.25 micrograms once a day. And remember, steady state is reached in 5 to 6 half-lives, and the half-life of calcitriol is 5 to 8 hours. So, you know, if you have made some changes, you started calcitriol, you can check your patient's lab tests in 3 to 4 days and make further changes. But go up slowly, 0.25 micrograms once a day, then check it 4 or 5 days later. If the calcium is still low, then go up to twice a day. Small changes with close follow-up is very important. If you make big changes with infrequent follow-up, the patient will become hypercalcemic or more hypocalcemia. So small changes with close follow-up. And thiazide diuretics can help to reabsorb that calcium through the kidney. Now, we looked at another systematic review, and we looked to see how PTH therapy compared to conventional therapy. And these are all the studies that we looked at. And we looked at PTH 1 to 84, PTH 1 to 34, and TransCon PTH, Palopeg teriparatide. And the PTH 1 to 34 and 1 to 84 were not ideal. The 1 to 34 has a 1-hour half-life. And so if you want to improve serum calcium and urine calcium for the 24-hour time period, you need to give it 2 or 3 times a day. The PTH 1 to 84 has a 3-hour half-life. And so it doesn't decrease urine calcium, 24-hour urine calcium. But this TransCon PTH does decrease urine calcium, and it has been studied in phase 2 and phase 3 trials. This is the phase 2 trial of Palopeg teriparatide or TransCon PTH, and it showed reductions in urine calcium, just once a day needle. And this drug dramatically improves the half-life of PTH. And you can see over here, this was seen both in the phase 2 and the phase 3 trial, that 91% of patients were able to achieve independence from standard of care. That means they were able to stop active vitamin D. And over here in the phase 3 trial, 93% were able to achieve independence from conventional therapy, and their calcium requirements were less than 600 milligrams a day. And there was a dramatic improvement in the quality of life, and also in serum calcium, urine calcium, and phosphate. And this is what this drug does. TransCon PTH is linked to a polyethylene glycol moiety. When it is given subcutaneously, it's given in the belly. Then it is released. The linker is cleaved with exposure to physiologic pH and temperature, and the drug will go on and bind to its receptors, PTH receptors, and the polyethylene glycol moiety is cleared through the kidney. So once a day gives PTH levels which are in the physiologic range for 24 hours a day. And we can see here, just in the interest of time, the phase 3 study, it was 26 weeks, blinded, TransCon PTH versus placebo, and then there's an open label extension. And I'll show you what happened in these patients. You can see that 100% of the patients were able to stop active vitamin D. And we can see that 95% of the patients were able to reduce their calcium supplement to 600 milligrams or less a day. So with this drug, we are able to drop the urine calcium, whereas with placebo, it was elevated. And even with the placebo, because these patients are continuing with calcium and vitamin D and they're being closely followed, what we're seeing is that the urine calcium is improving, but there was a statistically significant greater improvement in urine calcium with TransCon PTH in comparison to placebo. And if we look at the 3-year data from the phase 2 trial, we can see that there was a dramatic improvement, 91% achieved independence from conventional therapy. And you can see that serum calcium was in the normal range. Look, the urine calcium decreased, and the biomarkers are again activated, and the bone density, which was high at the beginning, reestablishes in a level that is similar to age-matched peers. The drug was very well tolerated. Most patients had mild to moderate side effects, and no patient had to stop the drug, and no patients died in this study. And if you look at what happened to the bone density, we can see that as the biomarkers increase and they come down and reestablish at a new steady state, and which is closer to the normative values for their patient population. And the same thing happens to the bone density. You can see in the various groups, patients' bone density is reestablishing at a steady state, which is closer to what we would expect for their menopausal status and their gender. So treatment with Palopeg teriparatide was able to maintain a normal serum calcium, normalize urine calcium. It actually normalized phosphate as well, and bone turnover was normalized, and bone density was associated with declines and establishment of a new steady state closer to what was expected. And there were improvements in renal function. And why are we seeing improvements in renal function? Probably because these patients are stopping active vitamin D and calcium, and we're normalizing urine calcium. We're taking them off conventional therapy. And also, the PTH has vasodilatory effects, and this could be the reason why post hoc analysis of the phase 3 data shows that PTH replacement and stopping conventional therapy may not only preserve but also improve renal function in patients with hypoparathyroidism. I just wanted to say a little bit about pregnancy. We talked about this last year, but remember that in the pregnant woman, there is PTHRP, which enhances the formation of 125D, and these patients are missing 125D. So in pregnancy, patients' requirements for active vitamin D and calcium may actually go down, but because of the developing fetal skeleton, their calcium needs are increased. So we need to follow these patients very closely, and we need to make sure that we are meeting the calcium needs of our pregnant patient. And so we are saying that in pregnancy, keep that serum calcium normal. Try and achieve a normal calcium, a normal phosphate, a normal magnesium, and a normal vitamin D throughout pregnancy, and measure every 3 to 4 weeks. Obviously, we don't give these people PTH, but we can give them conventional therapy, and we want to avoid hypocalcemia and hypercalcemia. And the goals of therapy are to achieve a normal urine calcium, a normal phosphate, preserve renal function, avoid kidney stones, avoid ectopic calcification, and have a serum calcium that is close to the normal reference range without developing hypercalcemia and without developing symptomatic hypocalcemia. But in the pregnant woman, we want a normal serum calcium. So with that, I'd like to thank you for your attention, and I'm happy to answer questions. Thank you.